And great, got it. So thanks for inviting me to present today. It's always great to be able to share the work more broadly across the country. So I prepared a few slides to talk about. I think about 15-20 minutes or so. Questions are welcome. This will be a pretty high-level overview. We're not going to dive into the nitty-gritty details unless somebody wants to, and we have time. But there's a lot of stuff in the actual documentation in the report itself that goes into some considerable detail. So with that, let me just give you a little bit of background. I've got my agenda here is just do, as I said, a little background, some of our partners involved with this work, sort of the project, the purpose, where this came from, why it's relevant now, some high-level primary learning and findings, and some recommendations, and hopefully have a little time for discussion as we go forward. And feel free to put questions in the chat if you like, and we'll pick those up hopefully in real time as we go forward. So just a moment on Stewards of Change. We're a nonprofit organization based in New York. I've done a lot of work, actually more work in California than anywhere else. And so we have been around for a while, about 15 years or so, and we really have focused on data sharing and interoperability, when interoperability was a four-letter word. And we also come at this work from a social services, justice, education perspective, as opposed to coming at it from the healthcare perspective. So we originally started in child welfare and saw all the disconnections in that field, and that led us to every other field that touches children and families, and of course healthcare over the years and the Affordable Care Act. About 4 years ago, we started something called the National Interoperability Collaborative with support from the Kresge Foundation, and had the good fortune of being able to build out a rather robust national network that's got, we've got about 5,000 people on our mailing list and our participants. And the purpose of this was to really bring together people who are thinking about interoperability, but didn't have a home, no, it's a virtual home to come together on. So I'm sure everybody's been in that position of recreating the wheel, or looking for who else is, somebody else must have done this already, so how do I find them? And so we were successful in actually building something like that and creating sort of a digital watering hole for people who are interested in this. And over particularly the last couple of years, and particularly over COVID, we've been focused on bringing together a national community. And so there's a lot of resources there. We held about 55 webinars sort of prior to COVID and during COVID that touched on a lot of the different topical areas. So I offer that because a lot of the work I'm showing you today is a result of the collaborative and the participants we've had in that work group. Obviously, can talk more about that. So the background, as I said, we've convened lots of people over the years. What really, many ways, spurred this effort was some work we had done over COVID, called we did something called the National Action Agenda to Advance Upstream Social Determinants and Equity. Did this in partnership with Stanford Center for Population Health Sciences and others from across the country to really ask the question, what happens after COVID? Recognizing that the world was going to be in shambles, particularly the most vulnerable populations. And so what could we do as a national collaborative to bring something to the table? Well, we, I would say, tortured people for about 6 months with regular convenings and a lot of iterative online stuff. I affectionately refer to it as the interoperability support group during COVID. People kept coming back for more and more. And we had a tremendous, just a tremendous group and a lot of work that came out of it. We really wanted to do something that was actionable, that we could do as a coalition, as opposed to just a set of recommendations that somebody else should do. And so we narrowed it down to 6 action recommendations. And the one that really percolated at the top was this whole idea of consent. At the core of data sharing and interoperability are the attorneys. Dr. No, as we refer to them. No apologies to all attorneys on the call here, but their job is to minimize risk. Our job is to figure out how to get to yes. And one of the things that really stands in the way of that is consent. So it really came into focus as a result of all of the work we had done. And so since January, of last year, we have been working on this collaborative research scan project. So we did, scan, research, summarize, and then now actually, this is actually probably the first public presentation of this work. We've got some more coming up, but it's a delight to be able to share it with you guys. We also sought input from the Bronx Community Research Review Board, or people with lived experience. A lot of the work we're doing is focused on New York and on New Jersey, and 2 federal cooperative agreement sites called Integrated Care for Kids. I'll talk about that a little bit more later. But they're real sites with real kids and families trying to do interoperability. Our goal was to identify really emerging or promising practices, things that could be scaled, highlighted, and along with that, the key laws, policies, regulations, governance issues, and of course, technologies that could be brought to bear on improving and designing this work and being able to create a replicable open source consent solution. And I want to just pause for a second there. Our goal was to create something that was conceptually, the scan was done with the purpose of trying to support a proof of concept. And we want to do that in an open source way so that others can replicate it. So we identified and aggregated a whole set of resources in the report. At the very end of it, there's, I don't know, maybe 50 different resources related to consent and legal and stuff like that. So it's a really good bibliography. It's pretty fresh as well for folks who want to know more and dig into the details of it. We had, as I said, a bunch of partners, and this is the logos from many of them. San Diego was so well represented, we actually have them twice on the, just kidding. We have them twice on the list of logos. And Dan Chavez, who's here, has been a long-term partner of ours. And the reason I put this up there is it really is a collaborative effort. A lot of healthcare folks, a lot of social services, a lot of interoperability, technological folks, and it was really a group effort. And along with that came a lot of editorial rights, a lot of editorial efforts, which were conducted by Adam Pertman, who's joined us on the call here today. So fabulous editor and able to bring together 25 different voices in one document. Hopefully it'll look like one document. And of course, I want to thank Robert Wood Johnson Foundation for providing some funding for the work. And so it's available for everybody now. So why did we do this? Well, as probably most people know, consent processes are ancient, antiquated, generally paper-based. They're not accessible. They essentially obstruct information sharing across sectors, and they don't really do much for improving racial equity, economic disparities, and improving outcomes. Our goal really was to improve ultimately health, well-being, and equity through, and we use the word not just spuriously, but really dramatically improving services. And we think that consent is one of those structural changes that could be made, that can be made, that would actually have a material impact across the country in every community. And this is really the first examination and aggregation of consent-related activities in about a decade. The Office of National Coordinator did a report, actually MITRE did a report for the ONC about 8 years ago. This is really an update to that report, and hopefully it provides some insight and something that everybody can build on over time, as opposed to doing it from scratch. A lot of work there. And there's an urgency for doing this work. There's a tremendous urgency, especially around COVID, communities that are really in need of more integrated care coordination and services. So that was the drive for it. We also wanted to make sure we'd learn stuff that we could apply to an actual proof of concept. So while I showed the partners that were involved, we also looked at many of the folks involved in the sort of the ecosystem, one might call it. And many of these acronyms or names are things you're probably familiar with. But we spent a bunch of time, and folks from the ONC participated. They shared with us all of the resources that, so we wouldn't duplicate them. And we had good participation from the HL7 community, and then you can see others that were involved to really try to provide a comprehensive view. You'll see references of them throughout the initiative, or throughout the documentation. So from a high-level perspective, we broke our promising practices in these 5 categories. As we started to look around and sort through things, we discovered that, obviously community information exchanges, San Diego and other places, health information exchanges, HIEs, community referral services, industry and government initiatives, and electronic health records. Each of them had solutions or practices that were fairly discrete. And so we organized it that way. Of course, there's a lot of overlap between them, but it was a way for us to organize the thinking about that. And as from where you sit, they may become more relevant in terms of some of the examples. And we dive into some of the examples. I know I'm running a little short for time, so I'm not going to go through the highlights here. We'll share the PowerPoint with you. You know, there are a number of things. The conversation is happening. People across the country are starting to pick up this work. And the last point is unfortunate, is that really due to the pandemic, there's a more of an urgency. There's more of an interest in really doing data sharing, understanding the implications and the value of that. And that what we've got now is really sort of insufficient. A couple of primary learnings. It goes without saying, people from the community, involved with the community, need to be involved. It's super hard to do that, especially on technical conversations and legal things. We had the good fortune of being able to involve folks from the Bronx, basically the IRB community there, including a lot of both academic and other partners in the community. That was really helpful. We learned a huge amount about what we hadn't been thinking about, of course. Again, the country suffers from a patchwork of uncoordinated federal laws, state laws, as you know, California being probably the most stringent, although New York would compete for that in their own opinion, their own privacy laws. There's really no established structures for addressing multi-domain privacy and consent. Everybody's kind of the wild, wild west out there. And there's really no place to find a consent directive, regardless of where you are. So yeah, you have to kind of figure out how to wrangle and find them out there. There's, of course, an ongoing fear of non-compliance. Pinstripes don't appeal to everybody, and there's a terrible fear of running afoul of the law with data sharing, when in fact, many of the laws are in fact designed to help or to encourage data sharing. And it's important to remember that. You know, within the healthcare world, again, and we focus a lot on the healthcare work because there's been so much work that's gone on there. There's really very few consent standards, very few standards at all, no less consent standards outside of the healthcare space. HL7 haven't adopted that. Within the education world and the justice world, they have a whole different set of standards that they operate under. And as I said, the lack of maturity, being generous within the human services for lack of data standards, there really are none at the moment in time. And of course, you know, education investments are needed ongoing to really address these complex vexing problems. It won't get solved with individuals doing it. Need to really be a collective effort. A couple of next steps we want to continue disseminating the scan, and we encourage people to contribute to. We're trying to develop on our hub and some of the sites a way for you to contribute if you're finding things. And you know, just even yesterday we had a presentation from Missouri around their ELTSS program and intellectual disabilities, all sorts of good stuff out there. We're hoping that we can actually build on this thing and make it a living document. We want to, and we need to incorporate people with lived experience in all aspects of this. We continue to learn what we don't know and need to really pay attention to. And continue developing implementation plans. One of the exciting parts about this work is we started with an end in mind, and that end in mind was to actually create, design, and develop 2 proof of concept demonstration sites, one in the South Bronx in New York and one in New Jersey. We're open to other places. We'd love to have California part of that somewhere. But both those sites are part of the Center for Medicaid and Medicare Innovation program called Integrated Care for Kids. And they're designed to connect their Medicaid with social services, child welfare, education, behavioral health, and the courts. So it's a perfect site. They have 7-year grants. They're in their second year, starting the 3rd year. We hope to be able to launch something there with a variety of partners to be able to demonstrate cross-domain sharing between a couple of places. There's a lot of stuff on our website around that. So there's really a tangible implication for this work. It's, as I said, it's not just theoretical. We also are continuing and look forward to your support and the work that you do as well, advocating for federal agencies to coordinate a little better. I'll leave it at that. And also we want to, if resources are available, we think that consent is a terrific topic for an in-person conference. symposium. Last year we did it with Stanford virtually. We were planning on doing it in Palo Alto in January, but converted to a virtual conference. And we're hoping that if not there, somewhere else on the West Coast or East Coast, to really bring together these ideas, because you do have technology, you have legal, you have governance, and then you have sort of ethical issues, all of which represent good components of the work there. And so we will continue to conduct a series that we have our Wednesday calls. Robbie was part of it yesterday, and we'll be looking to put together an ongoing series focusing more deeply on the consent report categories to be able to go a little deeper into that with people who are subject matter experts there. And that's my contact information. So I went a little bit over, but hopefully I was able to give you a sense of what we're doing there. And if you're interested in questions in that, Robbie, or if you want to hold off on that, that's fine as well.
No, totally. And thank you for the presentation, Daniel. I think it was really helpful. And one question that comes to mind, you mentioned incorporating people with lived experiences in this work. And I think this is something that's been coming up with the state's stakeholder advisory group to create this state data exchange framework, is how to meaningfully engage patients and caregivers in, the data exchange framework and governance, and think about their needs, both in terms of, any sort of tools or infrastructure that's developed, but also I think too within the process. And do you have anything to share that might be helpful for California stakeholders as they think about how to, engage, patients and caregivers in this work?
I'm not sure we've solved that problem. We were lucky in a way. We were partnered with Montefiore Hospital. I suspect that, and they happen to have a community-based IRB group that they work with, because the Bronx is one of the most heavily studied counties in New York and probably the country. And they really recognize the importance of that. So we had, once we sort of made contact and sort of connected with them, they were interested and they gave their time to participate in it. So I would look at the partners you're dealing with, if they're hospital groups or FQHCs or others, they may already have those established contacts with, with community-based services. The challenge, as I said earlier, is you have, on one hand, you have sort of the professional sort of advocates who are part of that world, which it can be helpful and useful, but they come with an opinion that may or may not totally represent the community. And so it's not an easy thing to do. I would look in community, especially in some places, there are a lot of community organizations that are of the community that it takes some outreach, it takes a little patience, and doing it early on. That's why I emphasize really doing it early on, because that you have to create the relationship and the trust with them. One tiny, very short story with the Bronx, we were all excited about the technology, the solution, and the digital stuff, and the handheld, and the user interface. And they said, you know what? Our people really would like the paper copy to be able to take home and talk with their family, because they're not so excited about sharing all their information. And there are a lot of other considerations that people go through that, again, we didn't think about at all. It's an area that really, I don't think there's a sort of a broad solution to it. It takes a lot of hard work and authenticity and trust building, I think.
Excellent. No, I think that's really helpful and insightful. I see a couple of questions came in from Claudia. Maybe the last one around the consent model. Does it address data segmentation and redisclosure, or just the consent documentation?
So we worked with DS4P and also PP2BI, which are really looking at data segmentation. And that work is in development, I might say. I don't think it's there yet all the way, but there is progress there. That's the good news. The not so good news is that integrating in any of the social programs is really on the sort of, I think I would say, the long-term roadmap. Jim, others correct me, or Brian, if I'm wrong here, but just trying to get their arms around the healthcare, the diagnostics and the clinical work is super hard. And no less on the behavioral health side. So we do address it. Again, we don't go into great detail, but there was involvement with both of those groups in the work, and you'll see some reference to it there. I don't know if I answered your question.
Hey, Robbie, can I jump in? Thank you, Daniel.
Sure.
You struck me when you said the legal doctor no. Where we see that or run into that quite a bit is at the state. And I'm wondering how you're approaching state education and also resource for state legal interpretation. And, what would your recommendation be as a state that, we have a tremendous, we have our work cut out for us from the city to the county, to the state, to the region, across every which way you can imagine.
Yeah, so a couple of very quick things. One is the Administration for Children and Families recently published or republished an updated toolkit for privacy or confidentiality. It doesn't go as broadly. We've written the first one for them a bunch of years ago, and it doesn't really take into consideration all the really hard stuff, but it is a good federal basis for some of the ACF programs. And that's always good. That's kind of, chapter and verse to take to your state partners. Like, the feds have said this, which is what my experience, states always say, well, we can't do it until the feds figure out what they mean by for treatment purposes, right? Or whatever it might be. So that's a good place to start. I know SAMHSA's, they've published new regulations around more granular consent. I think those are going into place. Well, I think the policy was published. I don't think they're actually implementing it until maybe 2022. I know it got pushed back a little bit. Again, another seminal document for 42 CFR as a way to go. The challenge always, and I discovered this in California, is even though there's state law, the county privacy officers sort of interpret it differently. And that was one of the crazy things that crazy making. It's like, wait a second, there's state law. Same issue just came up in Virginia between two different counties. It's like they have slightly different interpretations. The privacy officers are comparing it to a different standard. And I don't understand that. I don't understand why they are, quote unquote, allowed to do that, from a county perspective, their state law and the interpretation. So we've sort of knocked on that door a couple of times to try to standardize across the state, because that's part of the vexing problem is you figure it out in LA and, Riverside doesn't want to do it because they're privacy officers. So
need an arbitration.
Yeah, exactly. And I don't understand why that would be, but smarter folks have tried that. So.
And I just, one other just final question is, you said that you would love to work with some folks in California as part of your pilot projects.
Yeah.
How do you envision that? What kind of hand raising would you like? How do we get the word out?
Well, I might say here, and call on Jim as well, just to wave your arms. We're developing a partnership with Linux Foundation for Public Health because we really want this work to go into the public domain, and we feel like they're the best partner for a whole set of reasons to house this work. As I said, we have 2 sites that have raised their hand. They're interested. We've been working with them for a while now, but we would look for a site that would, it's in the middle of doing some, maybe not too far down the line, but trying to do some data exchange between health and other sectors, education in particular, social services in particular, to do, to really extend out this proof of concept on a very granular basis. We're not boiling the ocean, but to have another site that would be willing to bring that to the table and some resources. We have some technology partners that appear to be willing to bring in kind, but there's some resource requirements to be able to do the project management, education, those kinds of things. So we think that now is the moment to do this work. It has huge impact on everybody. And if we could get a few sites across the country that are actually working on developing something that we can point at, I think that would be a super success in 2022.
Fantastic. Well, I think Jim, we can follow up with you on that as well. But then I would also just ask Daniel, think about us and the education opportunities that you have. We would love to share share that out with our distribution list as well and engage. So we look forward to, figuring out how we might be able to partner going forward.
great. I love the opportunity and happy to talk, online, offline, come back to, we've done a lot of stuff in this space. So happy to share it and happy to come back to California to share it with you guys as well.
Well, thank you. And thank you. I think everyone would agree. It's great to have you as a resource. So thank you. Keep it going.
Yeah, we're trying.
So I think we're going to change gears real quick. Thank you so much. And move on to the work that we're picking up again, which is the access to